Ladies and gentlemen, good afternoon and welcome to the Medtronic Satellite Symposium during EACTS Annual Meeting 2020, titled Optimal Cardiac Surgical Care. Are we there yet? Your hosts will be a faculty of international experts who will cover a great variety of topics around optimizing cardiac surgical care. Professor Robert Klautz will present new 4-year data of the Perigon trial with the Avalus pericardial aortic valve. Dr. Niels Verberkmoes will present his concept and results on the surgical treatment of standalone AF. Professor Omer Dzemali will present his views on tricuspid repair and his initial experience with the new Triad 2.0 tricuspid band. The live panel discussion in the end will be moderated by Professor Thomas Modine and Professor Michael Borger, and we will have the opportunity to address questions from the audience at that stage. Now please let me introduce Professor Robert Klautz from Leiden as our first speaker, presenting on the new results of the Perigon trial.
Ladies and gentlemen, I would like to present to you the 4-year data from the Perigon trial. The Perigon trial evaluates the performance of the Avalus valve that was developed by Medtronic. A bunch of surgeons, including myself, were involved with the early design phases of this valve and also the design of the trial. It's probably one of the last valves that will be developed in the surgical arena. And it's also a very important trial because it's large and it sets the standard for the future of surgical AVR, and therefore I think this is a very important study, not only in the evaluation of the performance of this valve, but also in understanding what's the current gold standard for surgical AVR in this time frame. The Avalus valve has some important features. It's a bovine stented pericardial valve with a low profile height. It has a supraannular design, and the base frame material is impregnated with barium sulfate for radiographic visualization, and that helps in doing valve-in-valve TAVI in the future. It has an anti-calcification treatment with AOA. It's a treatment that's been used by Medtronic for a long time on several valves and been shown to be very effective in improving the durability of these valves. It has a very flexible sewing cuff and comes in sizes from 17 to 29. So that is short for the introduction of this valve. As for any valve, it's very important to understand the proper sizing you have to apply to get the perfect result. You start by measuring the left ventricular outflow tract of the patient with the barrel end of the sizer. The barrel end of the sizer is numbered and the valve is labeled, with the exact diameter of this barrel being the number in millimeters. So the size 23 sizer corresponds to 23 millimeter in diameter. So you size the LVOT with an exact sizer, a metric sizer. That diameter corresponds to the mid portion of the valve frame. Therefore, you get an optimal match between the outflow of the patient's left ventricle and the opening of the prosthesis, just the tissue of the leaflets then exposed to the opening of the left ventricle. The replica end of the sizer you can use to judge whether the valve will fit into your aortic root. Some patients have a very aortic root, and although you would like to use this size valve, it may not fit into the root. And then it's up to your decision whether you go one size smaller. I will show you in the trial that the valve has a very low gradient, so that should not be a big issue. Or you can choose to implant that valve size, but you may need to patch closure the aorta, which in my experience you need in about 1 out of 10 patients because they have such a narrow aorta that you cannot close it over the valve prosthesis. But that's not only in this valve, that's in any bioprosthetic valve, stented bioprosthetic valve I use. Let's talk a little bit about the trial design. The primary analysis was the comparison of linearized valve-related adverse event rates with the objective performance criteria for valve-related event rates. Basically, we compared several endpoints to what's set in the literature as a certain standard. Those standards are called OPC standards. The safety endpoints were death, thromboembolism, valve thrombosis, hemorrhage, paravalvular regurgitation, and endocarditis. We also looked at the effectiveness endpoints, basically functional classification according to NYH class, and hemodynamic performance, including EOA and mean aortic pressure gradient. We wanted to include at least 1,000 patients in 38 centers, 13 in Europe, 25 in the US and Canada. In the US, Joe Sabik was the principal investigator. In Europe, that was myself. We used the MedStar Echo Core Laboratory to assess all the echocardiographic examinations, the pathology lab for the explants. There was a clinical events committee and a DSMB. Medtronic did all the data recording and analysis, but the PIs had complete access to all the data. We already have several publications on the trial data itself. We have published in several journals and gave several presentations on this topic also at the EACTS meetings in previous years. But you've also have done several publications, and publications are coming on the following subjects. PPM, does it really exist and what is it exactly? On the EOA charts and how to use them and whether we should use them, and the inaccuracy in these EOA charts. There's a manuscript on exercise hemodynamics. We're presenting here on the ACTS a paper on mini AVR, a suture technique paper will follow, and several others. So this trial will give us not only data on the performance of the Avalus valve, but also learn us much more about aortic valve replacement in this current era. It's important to understand what kind of patients we included in this trial. And basically, if I summarize what's in this slide, it's the average AVR patient. On the left side, you can see that they had to have moderate or greater AS or AR with clinical indication for valve replacement, with or without other comorbid problems like coronary artery bypass grafting, ascending aortic aneurysm. So many concomitant conditions that we currently see for AVR were allowed. We did not want to include patients where their future prognosis would be too much dependent on other diseases. For instance, other valve disease or endocarditis or other problems, and you can see basically those were much sicker patients, and we didn't want to include those in the trial. The baseline demographics of the patients that were eventually included in the trial are listed here on this slide. We included 1,116 patients, so a little bit more than the thousands I previously mentioned. The average age of the patients was about 70, with 3/4 being male. A normal distribution for this kind of patients was most in NYH class 2 or 3. The STS mean score was 2.0. And on the right side, you see the comorbid conditions. There at about 10% had atrial fibrillation. It's important to remember this number because those patients obviously have anticoagulation. And as we saw some patients with late hemorrhages, that's probably related to the fact that 10% of these patients already had anticoagulation due to other conditions than their valve. Almost half the patients had coronary artery disease and 1/4 had diabetes. So it's the average AVR patient population of that age, I would say. The procedure data are listed here. 84% of the patients were operated for pure aortic stenosis, 5.6 aortic regurgitation, and in 10%, almost 10% had a mixed problem. The surgical approach was 80% was immediate sternotomy, so 20% of these patients had some form of minimal access approach. You can see on the right that about half the patients had a simple aortic valve replacement and the other half had a concomitant procedure, of which CABG was the most prevalent procedure in 32% of the patients. The valve distribution is listed on this slide, and you can see that size 23 was the most prevalent size, and otherwise a normal distribution over the various sizes, with very little or none 17 and only very few 29s. I would like to present the 4-year outcome now of the trial. We start with all-cause death. At 4 years, this was less than 10%, which is very low for this older patient population with this mixed comorbid conditions. And it's clearly attributed to the excellent performance of the surgery by the centers. And I think this shows the contemporary possibility for outcome of patients with AVR. 4 years and only 10% all-cause mortality. About half was cardiac, the other half was non-cardiac related. Freedom from explant was 97.3% at 4 years, so very few explants, and the majority was due to endocarditis. Reintervention 97.2, it's about the same number. And here you can see the late linearized event rates I talked about earlier. You can see in the thromboembolism is lower than expected, so that's good. Valve thrombosis, it's about the same. It's a very few patients, so it's hard to say that it's lower or higher, but it's in the same range as the OPC standard. You can see that the hemorrhages were higher than the OPCs, and that's probably because of their co-comorbid conditions. We analyzed all these hemorrhages, and indeed, the majority was in patients that had already anticoagulation for other reasons, being either atrial fibrillation or, as you've seen, over 1/3 of the patients had concomitant bypass surgery, and obviously all those patients had platelet inhabitants, and therefore I think you could say that this is a reflection of the concomitant problems of these patients. Paravalvular leak, especially major paravalvular leak, was much lower than expected, and endocarditis was also lower. So overall, the valve performs well, and I think the hemorrhages, we have to see whether these OPC standards and those definitions may need to be changed in the future as AVR is performed in patients that have already anticoagulation for other reasons. Very important, the echocardiographic findings in this trial. In blue, you can see the reduction and constant mean gradient over time. Preoperative mean gradient about 42, going down to 13 and staying stable over time. I think it's important to realize that over the 5-year follow-up time, that gradient stayed very, very stable over time. The EOA increased obviously from 0.9 to about 1.5 and also was stable. I'm not a big fan of EOA. It's calculated, it's based on many assumptions, and that's not always true in most patients. So I really like to stick with the gradients, and I think that they show that the valve performs very well. Transvalvular regurgitation is depicted in this valve, and you can see that the majority of patients have a almost perfectly competent valve. More than 95% of the patients had only less than mild central regurgitation over time. So it's not going to leak over time, basically. And if we look at the NYH classification, and I think this is the most important slide of the whole presentation, you can see that 3/4 of these patients, although there were a mixed group of patients, were in NYH class 1. And if we include then NYH class 2, that most of the patients are basically very little symptomatic or asymptomatic. And you have to realize again that these patients not only had aortic valve disease, but also had coronary artery disease, diabetes, and other comorbid conditions. So I'd like to conclude that this trial demonstrates that the safety and effectiveness of this valve. The overall mortality and valve-related events were extremely low. The mean gradients were comparable to or lower than for other valves, and central regurgitation compares very favorably to other valves. This trial is a very important trial. It's the contemporary gold standard for aortic valve replacement, and we're going to learn a lot more about not only this valve, but also the treatment of aortic valve disease with aortic valve replacement, surgical AVR in the future. And I'm sure that this trial will give a lot more about this trial in the future than just the performance of the valve. Thank you very much.
Thank you very much, Professor Klautz, for this first presentation. We will have the opportunity to address questions regarding this presentation during the panel discussion in the end. Now let me introduce Dr. Niels Verberkmoes from Eindhoven, who will share his concept and technique for the treatment of standalone AF patients.
My name is Niels Verberkmoes, working in Catharina Hospital mainly. My field of interest in cardiac surgery is minimal invasive arrhythmia surgery. Hopefully you will love to listen to the next presentation about this subject. I will start the presentation. And I'm happy for everyone who's looking at this meeting to make a presentation about our treatment modality for patients with atrial fibrillation. It's a concept for standalone treatments for long-standing persistent, and I want to guide you through the evolution of our strategy to treat these patients. There are some important basic considerations that you really should take in mind following my story. And that there's probably some open doors, but the only incentive for having a new procedure in your hospital or in your community should be the patient. And the patient should be your only incentive. There should not be any financial driven or any other argument to change a protocol or change your therapies. And sometimes you have to say goodbye to your old-fashioned boundaries of your own medical specialty, and you should think a little bit out of the box. Thereby should be the guidance that the whole is greater than the sum of parts, and every individual doctor is not important enough. So a real clear message that will follow during this presentation: try to form a real team, and I will come back to that. And especially for the surgeons looking on this, try to speak the same language as the cardiologist, your EP, your referral centers, and really try to understand their theories, their hypotheses in the treatment of atrial fibrillation. So learn to speak the same professional language. And that's actually also written in the guidelines, that if you start a program for integrated atrial fibrillation management, the clear message from the guidelines is actually form a multidisciplinary team. The point actually is that a lot of people in medical science think they are a team because they work together. But on this picture, you see myself with my family, with my team. And we are a team not because we work together, but because we really trust each other. And that's the same in family life as in working life. Therefore, we did a lot of training to really trust the team members, both in the OR as well as our cardiologists, and of course also in family life. And we changed our fundamental philosophy in our home clinic, that the patient's disease is the guiding principle of care. So every component that affects the patient's heart disease is treated by the collaborating team. So thereby individual knowledge and skill are shared as much as possible among the medical specialists. Thereby, every disease has multiple team members, and no patient is treated by one specific doctor. The only thing is that in international literature, you see a lot of international fights about what's the best treatment modality, catheter versus thoracoscopic ablation for atrial fibrillation, and on and on. But the most interesting paper I read during last years is actually the CASA-AF randomized controlled trial. And this was presented last week on ESC. And this is the first randomized controlled trial to compare thoracoscopic versus cardiologic treatment in patients. But this is the first setup. So this is the index procedure. And for me, this slide shows really why we should rethink our treatment strategy. As you can see, there is actually no difference in cardiology treatment or surgical treatment. And there is no difference in atrial fibrillation or AF burden. There is for both procedures the same reduction. And you can imagine that the catheter ablation has some less collateral damage for the patient. But most interesting is actually what happens after 12 months is that both procedures on their own have a very low success rate. And that's what we are advocating for years now that it's not only about the endocardial treatment or the epicardial treatment, it's about the combination of these procedures. And therefore, we should stop discussing about what is the best treatment, but we should discuss about what's the most effective sequence and effective roadmap in treatment for atrial fibrillation to ensure the patient have the highest chance to cure from this disease. If the disease is a disease and if it's treatable at all. The success of a treatment is not depending on the treatment, but the success of a treatment is depending on the selection of patients. And therefore, it's very important that when you start a procedure, you should rethink your complete protocols. For me, patient selection is important. And of course, we discuss with the heart team if the patient needs advanced surgical treatment for atrial fibrillation. And it takes around 40 to 60 minutes per patient. You have to imagine that most patients are treated for over years and they are treated by cardiologists, but sometimes none of them has told the patient what is the disease they have and what are the treatment options. So our strategy is, in first instance, we try to treat all patients with endocardial ablation for the pulmonary veins. And after the failure of a cryo procedure, we do a redo procedure with complete mapping and completeness of the pulmonary vein isolation. Patients with irrefutable long-standing persistence for more than a year are sometimes immediately referred to the surgeon, but we tend to also have these patients treated with cryoablation. Severe dilatation of the left atrium, you can discuss a little bit about if you should refer them first to the surgeon and afterwards for an endocardial touch-up, but that's a discussion we won't have today. Of course, patients with anatomical abnormalities would be treated by the surgeon as an index procedure. We have some exclusion criteria for index procedures. That's paroxysmal prior cardiac surgery, concomitant cardiac surgery, very large volume in the chest, patients untolerate to have a single lung ventilation and a body mass index over 35 kilogram per square meter. On my out clinic, I have a very important principle, and this is the principle of primum non nocere. And that principle should be very important for every surgeon. The most important question is why not to operate on the patient. But if we have no other answers and the patient confirms that the complaints he has from atrial fibrillation is invalidating and has a serious impact on his life, then you should treat the patient. But also discuss all the alternatives as doing nothing, medical treatment, redo percutaneous treatment, and the risk versus benefit versus recovery. I will come to that. I will guide you through the surgical procedure, which is a very short video of our procedure. There are some variations that you can adopt in your own clinic, but we believe this is the most safe, most direct, and best reproducible procedure there is with the Dzemali S. We start on the left side, and I believe starting on the left side is a more safe way to enter both sinus. We use very hot water to prevent damp on the scope. There are all kinds of strategies, but for us, this is the most effective strategy. We start opening the pericardium on the left side below the phrenic nerve, very low, very close to the pulmonary veins. We use scissors for that, but all kinds of instruments can be used for it. To learn and to guide our EPs on later procedures, we do an epicardial mapping of the pulmonary veins and the posterior wall of the left atrium. Also to learn the effects of cryoablation and redo radiofrequency ablation. Here we enter the sinus, and we open just left from the right inferior pulmonary vein, and we enter the pericardium on the other side. Because there is no anatomical structure behind this pericardial fold, it's impossible to have any bleeding if you keep in the good planes. And on the other side, as you can see that we enter below the cable vein, superior cable vein. We open the pericardial fold on that side, And also on the right superior vein, there are no anatomical structures that can give you severe bleeding. If you prefer to start on the right side, opening these both sinuses, you can enter a lot of anatomical structures that give serious bleeding complications. We have two guidings that will guide us, guide our Dzemali S clamp by making a box lesion. Because the strength of the Dzemali S is, I think, that you have a bidirectional, bipolar left atrial box lesion. As you could see from the case IF trial, which was not done with the Dzemali S, having an incomplete box leads to a very low success rate of treatment of AF. So we guide also the other guiding, and then we go to the right side. The video switch to the right thoracic cavity. We open the pericardium above the phrenic nerve, and we stop at the end of the brachiocephalic vein. We open a little bit to the inferior cable vein. You can use a retraction suture to have a better exposure. It's not really necessary, but it could help you exposing the pulmonary veins on the right. We pick up the guiding, the blue guiding, and we pick up the gray guiding. And then when they are outside of the thoracic cavity, we connect the Dzemali S clamp. Here we are opening the groove of Waterston, which is not really necessary because you can ablate, but this is my personal opinion, and I like to have it open, but in the beginning it could be very dangerous. Then we pick up both guidings from the middle port on the right side. We change the camera to the most caudal port. This is that we can enter the Dzemali S more straightforward and without having much torque on the ribs, because torque from clamps and instruments will give pain on the patient's postoperative phase. So we enter first convex. This is a little bit more easier than concave in the first ablation period. But now you see the concave side first. It's just an issue of editing the video. We wiggle the clamp and then we support it a little bit with a fenestrated grasper, and we occlude the right pulmonary veins, and we do an ablation strategy of 5 times a transmural lesion on the convex side and 5 transmural lesions on the concave side. So the clamp is turned around and then again is placed on the pulmonary veins, and half of the floor and half of the roof lesion will be finished by doing this introduction of the clamp. The convex and concave strategy is because we believe that crossing the lines from both sides will be better, and this will assure a complete box lesion. In very difficult cases, it could be an option just to do a convex ablation, but then you need to do 10 times a convex ablation on the right and 10 times a convex ablation on the left. We like to close the right pericardium. It's not really necessary for the procedure, but in case of return of the patients with mitral regurgitation or other valve pathology, the right lung won't be stuck to the right atrium. In the final phase, we go back to the left and we connect the Dzemali S again to the clamp, and both convex and concave ablations are made on the left pulmonary veins. In this video, it's only showed convex, but we do it also 5 times convex and concave. You need to support a little bit the clamp with the grasper to steer the clamp. It's a non-steerable clamp, but it's a flexible clamp. And in the end, we make an amputation of the left atrial appendage for multiple reasons. The most important reason is to exclude the left atrial appendage from the electrical activity from the heart. There are some indications that the clot formation and the risk of stroke is lower with closing the left atrial appendage, but that's another discussion. It's not important for this specific talk and presentation. For me, it's very important, not the device by which you close the left atrial appendage, but it needs to be closed at the base, and it needs to be fully closed, so no remnants should be there. What also is important after the procedure is that you make yourself confident with the cardiac mapping. I did a lot of training with my EPs to understand what the cardiac mapping means and what's the importance of mapping. Just a small summary, you have an entrance block and an exit block. Entrance block is loss of a signal within the isolated area, and exit block is loss of capture during pacing within the isolated area. So if you have the isolation lines, you can see on the image on the right upper corner. So if capture of the heart is not possible, you have successful isolations of the PVs and the left atrial box. You need the MAPS device for that with the complete setup. And with this device, you can map, ablate, pace, and sense. We mostly use only the pace and sense function for confirming our complete box lesion set. It's important not to sense on your ablation lines, but really sense in and out of your box for perfect conduction testing. And then you learn something that mostly after cryo learn the EP language, but what most findings are that medial sleeves are not isolated. The right inferior pulmonary vein is mostly not isolated. Antral lesions are mostly not isolated, and the left common trunk is mostly not isolated. And box lesions, I've never seen them complete, and that is also seen in the KCIF trial. It's very difficult to make a complete endocardial box lesion. And another interesting finding is what I call cryo gray zones. Overactivity is that around the cryo lesions, you can see all kinds of re-entries that can create, again, atrial fibrillation. There were some interesting papers on the topic, and then with my friends from Leiden, we did a study with the different methods for having a complete box lesion, and we tried Medtronic Dzemali S, and on the other hand, AtriCure, and that's the reason why I really believe that this strategy is very successful. Because with the complete box lesion, what we saw is in comparable groups that there was not really a difference in success, but we saw recurrence rates were higher with an incomplete box, and with an endocardial touch-up from the cardiologist. The final results were the same, but it's important to have a direct box lesion. As you could see, most recurrence in the clamping group were atrial fibrillation, and in the non-clamping group were mostly flutters due to inadequate unidirectional ablation from the epicardial side. And also after 5 years, it's very important to know that, that in a big group of patients, that's with a very safe and very good post-operative result, and just a few small complications and a very good follow-up by cardiologists, we saw that 20.8% of 77 patients had recurrences, mostly re-isolation in the box, and some ablation because of isthmus and right atrial lesion problems. For us, this is also an important finding that the collaboration between the cardiologist, EP, and surgeon should be on the base of the surgical procedure. This is a very interesting picture was presented by a colleague from Brakel, on, I think, EACTS Lisbon last year, but I want to rehearse it because it's a very important picture that after 5 years, you have a very good result. And what they did was, of course, with continuous monitoring, you will find more recurrences. But the question is not if the patient has a lot of recurrence, you should actually look at the burden for the patient. So for me, in conclusion, after the strategy endocardial followed by surgical procedure has a very high rates of sinus rhythm at 5 years of follow-up. Continuous monitoring detects early AF recurrence. We have to discuss later on what we should do with these patients and if we should follow another roadmap. 66% of patients is in sinus rhythm after 5 years follow-up. We really have to understand that this is not a curative treatment. There is nothing clear about progression of the disease. There is nothing clear about which patient we should select. And we should follow these patients for reconduction from the box lesion. So epicardial ablation is safe. You can discuss with your electrophysiologist that it's also effective. But of course, it needs some serious recovery time. And we follow an aggressive redo strategy, call it stage hybrid, collaborate with your EP. This will give more success. But finally, most important is patient selection. Patient selection is key. And I think as a surgeon, which could be very difficult, is that we dare to say to a patient that there are no treatment options also. So to improve the success for epicardial ablation, we should go in the direction of a better patient selection. I think this puzzle will fit if surgeon and arrhythmologist or EPs work really together in a good manner. Thank you very much. Hopefully you enjoyed the presentation and we can discuss every question later on. Thank you very much.
Thank you, Dr. Verberkmoes, for sharing your expertise on the treatment of AF and the Dzemali S procedure with the audience. Now, for the final presentation, let me introduce Professor Omer Dzemali from Zurich, who will share his perspective on tricuspid repair and his initial experience with the new semi-rigid tricuspid band, Triad 2.0.
Dear colleagues, dear madams, dear sirs, thank you for inviting me to talk about the optimizing tricuspid repair. I will show you my initial experience with the new Triad 2.0 annuloplasty band. The disease of the tricuspid valve is mostly seen as a tricuspid regurgitation in adults. It is the most common right-sided valvular heart lesion. The data and content included in this presentation express only the clinical perspective of the presenter. They are completely independent and do not necessarily reflect the opinions of Medtronic. This is the way I would like to guide you through this talk. First, anatomy, second, etiology, and then pathophysiology. After that, the way how to evaluate the disease. Then the fifth point, the prognosis, and the sixth indication for the surgical approach. And last but not least, the treatment itself. An appreciation of the complex and variable anatomy of the tricuspid valve is essential to unrevealing the pathophysiology of the tricuspid regurgitation. A greater appreciation of irregular and abnormal anatomy is very important as new methods of surgical treatment of the tricuspid regurgitation are developed. In addition to etiology, pathophysiology, and the knowledge of the anatomy of tricuspid valve is crucial and mandatory for the repair. The evaluation of the valve pathology and pathophysiology and anatomy is important for the indication in order to get a strategy for the treatment. Understanding the anatomy of the right heart and tricuspid valve helps elucidate the multiple mechanisms that results in secondary tricuspid regurgitation. The tricuspid valve anatomy, including the annulus, leaflet, and papillary muscle, is unique for each particular person. The regular tricuspid annulus is a saddle-shaped structure with the highest points in anterior-posterior orientation and the lowest point in medial-lateral orientation. In patients with functional tricuspid regurgitation, the annulus dilatates along the right ventricle free wall and becomes more circular and planar, lose the saddle shape. The tricuspid annulus is a very dynamic structure and can change significantly with loading conditions. During the cardiac cycle, even in an atrial systole, there is approximately 19% of reduction of the annular circumference. Normal tricuspid valve diameter in adults is around 28 mm. Significant tricuspid annular dilatation is defined by a diastolic diameter more than 21 mm per meter square. Transferred to the clock phase, the annulus contracts from 12 to 6 o'clock. The tricuspid annulus is about 20% larger than mitral annulus. The valve consists of 3 leaflets named after their positions: the anterior, posterior, and the septal leaflet. The normal orifice of valve area in adults is 4 to 6 centimeters square. Since the valve is nearly vertical, approximately 45 degrees to the sagittal plane, the anterior leaflet is also referred to as superior, while the posterior leaflet has also been called inferior. The anterior leaflet is the largest leaflet. The septal leaflet is usually the second largest leaflet, while the posterior leaflet is most frequently the smallest of the 3. Let's talk about the etiology. In general, the primary tricuspid regurgitation is caused by an abnormality of the tricuspid valve and/or its subvalvular apparatus due to congenital or acquired causes. Acquired causes of primary tricuspid regurgitation includes tumors, iatrogenic injury, endocarditis, systemic disease, radiation, rheumatic disease, and trauma. One of the most frequent etiologies of acquired primary tricuspid regurgitation is the presence of the transvenous pacemaker leads crossing the tricuspid valve. In secondary tricuspid regurgitation, the underlying mechanism is characterized by right ventricular dilatation and dysfunction, which is leading to leaflet tethering, tricuspid annulus dilatation, and leaflet malcoaptation. Other causes leading to pulmonary hypertension include primary pulmonary hypertension, pulmonary embolism, and chronic pulmonary disease, similarly leading to increased right ventricular afterload, right ventricular remodeling, and dysfunction. In the absence of pulmonary hypertension, intrinsic right ventricular disease, such as arrhythmogenic, right ventricular cardiomyopathy, or myocardial ischemia in inferior infraction can lead to tricuspid regurgitation through papillary muscle displacement, increased tethering of the tricuspid valve leaflet, and leaflet malcoaptation. Let's see the pathophysiology. Primary structural abnormalities of the tricuspid valve apparatus or secondary abnormalities due to myocardial dysfunction or dilatation are responsible for the structural incompetence of the tricuspid valve. In mild to moderate cases of tricuspid regurgitation, no major hemodynamic consequences are noted due to the comparatively compliant nature of the right atrium. However, in severe cases, right ventricular volume overload develops that eventually results in right-sided congestive heart failure, presenting with peripheral edema, ascites, and hepatic congestion. When we talk about the evaluation, as it is known in the patients with mitral regurgitation, a better understanding of the mechanism for pathophysiology of functional tricuspid regurgitation, we could potentially suggest ways to improve surgical treatment. Unlike the aortic and mitral valve, It is not possible to visualize the all tricuspid valve leaflets simultaneously in one cross-sectional view by standard 2D echocardiography, either in TTE or TE, due to the position of the tricuspid valve in the far field. The tricuspid valve tethering area and end diastolic tricuspid annulus diameter show us that they are independently related to functional tricuspid regurgitation. In particular, the close association of end systolic right ventricular eccentricity and sphericity indexes with functional tricuspid regurgitation severity clearly shows that right ventricular geometric change independently determines functional tricuspid regurgitation severity. The algorithm for relating color flow area parameters of tricuspid regurgitation severity are less well developed. The color flow area of the regurgitant jet is not recommended to quantify the severity of tricuspid regurgitation. The color flow imaging should only be used for diagnosing tricuspid regurgitation. When feasible, the PISA method is reasonable to quantify the tricuspid regurgitation severity. Effective regurgitation orifice area more than 40 millimeters square or right ventricle volume more than 45 milliliters indicates severity of tricuspid regurgitation. The systolic hepatic flow reversal is specific for severe tricuspid regurgitation. It represents the strongest additional parameter for evaluating the severity of tricuspid regurgitation. Mild tricuspid regurgitation is seen in up to 60% and moderate tricuspid regurgitation in up to 15% of healthy individuals. Mild or worse tricuspid regurgitation in a valve with thin leaflets, normal coaptation, and normal appearing supporting structures suggests regurgitation is physiologic or functional severe. In carcinoid disease, the leaflets are thickened and retracted with a fixed orifice, usually leading to predominant regurgitation and less severe stenosis. Approximately 30% of the patients with mitral valve pathology have redundancy and prolapse of the tricuspid valve, leading to tricuspid regurgitation. In patients with severe mitral regurgitation or severe aortic stenosis, moderate and severe tricuspid regurgitation is present in more than 25% and 40% respectively. In case of underlying left side heart disease, a conservative approach was historically advocated regarding treatment of concomitant tricuspid regurgitation, assuming that the sole correction of the left side heart disease will lead to regression of tricuspid regurgitation. However, after surgical or transcatheter treatment of mitral regurgitation, aortic stenosis, or heart failure treatment, progression or late onset of tricuspid regurgitation was frequently seen. These insights have led to a paradigm shift in the current valvular disease guidelines, advocating a more preemptive treatment based on tricuspid annular dilatation, regardless of the degree of the tricuspid regurgitation. Let's talk about the prognosis of tricuspid regurgitation. Severe isolated tricuspid regurgitation developed 3 to 18 years at mean of 8.6 years after left-sided valve surgery. The tricuspid annular diameter and the right atrial area were already enlarged early after left-sided valve surgery. Severe tricuspid regurgitation often develops late after mitral valve surgery without significant left heart failure, valve dysfunction, or pulmonary hypertension. The increasing tricuspid regurgitation severity is associated with worse survival regardless of the left ventricular ejection fraction or pulmonary artery pressure. Severe tricuspid regurgitation is associated with a poor prognosis, independent of age by ventricular systolic function, right ventricular size, and IVC dilatation. Let's get a look on the guidelines. Actually, the primary tricuspid regurgitation is rare and caused by the abnormalities of the tricuspid valve apparatus. Tricuspid valve surgery is recommended in patients with severe primary or secondary tricuspid regurgitation. The secondary tricuspid regurgitation is far more frequent and related to right ventricular pressure and volume overload and dysfunction. It is resulting in annular dilatation and leaflet tethering. Surgery should also be considered for patients with mild or moderate secondary tricuspid regurgitation and a dilated tricuspid annulus diameter more than 40 millimeters, who are undergoing surgery for left-sided valve disease this stage. Tricuspid valve surgery is not recommended in patients with annular dilatation but no tricuspid regurgitation. Both the European and American guidelines state that isolated tricuspid valve surgery is indicated in symptomatic patients with severe primary tricuspid regurgitation and should be considered in asymptomatic or mildly symptomatic patients with right ventricular enlargement or deteriorating right ventricular function. Early tricuspid valve surgery is recommended for patients with severe tricuspid regurgitation undergoing left-sided valve surgery, irrespective of symptoms. Tricuspid valve surgery should be considered in patients with mild or moderate secondary tricuspid regurgitation and or significant annular dilatation. Late referral is associated with poor outcomes because right ventricular dysfunction is already established in many patients. Okay, I would like to talk about the cardiac surgery for the tricuspid valve. In our guidelines to operate tricuspid valve, we have 3 points which is very important. The first one, the restore of the leaflet motility. The second, the correct of a prolapse, not too high and not too low. Try to create a large coaptation surface of the leaflets and consolidate the annulus. And these are the points which we know from the mitral valve surgery. The surgical approach is either classical or bilateral approach, so-called minimally invasive. The surgery can be done with cross-clamping and cardioplegia, or beating heart without any cardiac arrest. As I mentioned before, the principles of mitral surgery are close the same for the tricuspid valve surgery. And now I would like to introduce you with a new triad ring, the so-called triad 2. It is the Adams tricuspid annuloplasty band. This is 2-in-1 tricuspid repair band with both flexible and semi-rigid annulus. The flexible ends is to preserve the 3D motions, and we have a large open area and a semi-rigid segment. The implantation is not difficult, it's easy, and as shown here, we have the possibility for measurements. And we have a large area on the septal space of the tricuspid valve to avoid the arrhythmogenic problems. The design with a semi-rigid segment at the free wall provides support with remodeling and has the target for the dilatation during diastole, which is physiological. They are soft, flexible segments to preserve 3D motion during cardiac cycle and supports the saddle shape of the native tricuspid valve. The large anterior septal open area with valve sutures minimize conduction risks to avoid to compromise triangle of Koch. They are different handle size, allowing for minimally invasive procedure, holder providing end-to-end support, and two prominent, easily visible cut points. They are size available from 26 to 36 millimeters. This is an example for our approach in mitral and tricuspid valve sparing surgery. It is a combined surgery with mitral valve replacement in minimally invasive technique via lateral thoracotomy and tricuspid valve repair in a redo case. Severe regurgitation in tricuspid valve position was shown here with mild in mitral position. The central cannulation on the ascending aorta, resection of the former implanted mitral ring, which can be seen here. Then the everted pledged arm U sutures and implantation of 29 biologic mitral prostheses and closure of the left atrium in cardiac arrest. So after the closing of the left ventricle, we will be able to open the cross clamping . And then in beating heart technique, opening of the right atrium, the great view on the tricuspid valve with dilated annulus. After the sizing, there will be the annular implanted U sutures and implant of one 32 millimeter ring. We see here the septal part of the tricuspid valve. And all of this in the beating heart technique, which allows us the reperfusion after the cross clamping of the aorta for the mitral valve. After implanting of the U sutures, we will be able to implant the tricuspid ring triad, which is shown here. And we see a good coaptation, and we are able now to close the right ventricle. And at least, let's see the results. We have a very great functioning tricuspid valve without the regurgitation. The triad design adapts to the three-dimensional geometry of the tricuspid valve in systole and diastole. There are three segments with two soft ends and a rigid mid-part. Braided sewing ring construction provides smooth needle penetration and prevents punching for easy implantation. As you have seen on the slides before, the tricuspid valve is a complex heart valve for indication and also for operating techniques. Most of the tricuspid valve disease are secondary. The reason for tricuspid valve regurgitation can be related on left heart disease or right heart disease. Please never forget to respect that in your indication findings. The conservative therapy is important, but in case of the left heart disease, please check annular diameter, also when insufficiency is not severe. The tricuspid annular dilatation is dynamic. It is also progressive, and these have to be mentioned. Secondary tricuspid valve regurgitation has more often indication for cardiac surgery than it is performed in real life. It is a positive predictor for long-term survival after surgical correction. Well, dear colleagues, I would like to thank you very much for your attention and for allowing me to talk about the complex of the tricuspid valve. Thank you very much and goodbye.
Thank you to Professor Dzemali, as well as the other two speakers, for providing so much insight into different aspects of cardiac surgical care. We will now have the opportunity to discuss these topics in more detail, as well as address questions from the audience in the panel discussion moderated by Professor Michael Borger and Professor Thomas Modine. And with that, I would like to hand it over to Professor Borger and Professor Modine.
Thanks very much for Omer Dzemali for his excellent presentation, which we just heard, of course. Niels Verberkmoes, then also with his excellent presentation, and Robert Klautz as well. We do have about 15 minutes here for questions and answers, and you can please send in your questions on the screen. You can see a place where you can type it in on the chat, and it will show up here on our computer screens, and then we can discuss that as a group. Maybe I'll start though with Robert with the first question. The early results or medium-term results so far for the alveolus valve look very encouraging. How do you think, as you know, lifetime planning for biological valves is a big topic now. How do you think this valve is going to perform in the future when we do need to do a valve-in-valve procedure? Do you have any experience with it? Is it did the developers of the valve take this into account when they came up with this concept?
Hi, Michael. Yes, thank you for your question. In the design of the AETIOLOGY valve, there was barium sulfate impregnated in the frame, in the base of the frame, and therefore on fluoro you are able to see the valve, which facilitates the valve-in-valve procedure for the future. So yes, there are things that make it more easy. The question is whether patients will come for a valve-in-valve, but we'll see. We have to see the long-term results of this valve. But I'm encouraged by what I see so far.
It is, of course, you brought up the issue about sizing, and that is one important take-home message for people here who have not previously implanted the alveolus valve, is that the size of the valve in relation to the sizer is a little bit different than some of the other bioprosthetic valves, and therefore you have to be very careful that you do not oversize, because then you can end up having, based on your sizer that you can insert, because then you may have troubles with obstruction of a coronary ostium. Maybe if you want to just, I know you covered that very well in your presentation, but is the size of the valve in relation to the sizer, this is always a difficult question. Is this anything that we need to really consider as long as the hemodynamics are good, or do you think this may have some impact in the future for a valve-in-valve procedure, like the discussions that we talk about for externally versus internally mounted leaflets?
Yeah, I think it's an important issue, Michael, because in general, I think every valve needs to be properly sized. And this valve needs to be sized with the sizes that come with the valve. And if we repeat that for a minute, you take the barrel end of the sizer, and with that barrel end, you size the LVOT or whatever passes through your annulus LVOT. And that will give if you take then that sizer, let's say it's a 23, then that's the distance of the mid portion of the base frame of that valve. So you get sort of a perfect match between the opening of the valve and the LVOT. However, not every patient will accommodate that valve in a narrow aorta, and therefore there is a replica end on the sizer where you can see how this valve will fit in the aorta. As we all know, there are several bioprosthetic valves that it's sometimes difficult to close the aorta if the aorta is very narrow. It doesn't mean that the annulus is too small, but the aorta itself can be narrowed to accommodate a large prosthesis. And with the good hemodynamics of this valve, you can either choose to take a smaller valve, or you need to patch to close the aorta. It's just unavoidable that in 1 out of 10 or 1 out of 20 patients, you may need a patch to close the aorta if you put in a bioprosthetic valve. At least that's my experience.
And maybe, Robert, if you can just finish up with that thought, what's your preferred patch material? If it's pericardium, do you use glutaraldehyde, yes or no? And do you use a 1-patch or a 2-patch technique?
For the aorta itself, it's only one patch, and I use xenopericardial tissue. It's easier to handle. It's quicker prepared, and I think that's for an aorta, that's fine. For leaflet tissue, it's different, but for the aorta itself, it's fine. And a double patch I only use if I go below the annulus, but you shouldn't go there. I think for this reason, you only may need to augment basically the non-coronary sinus and not more than that.
Yeah, I find that I used to do a lot of aortic root enlargements back when I was in Toronto. We implanted a lot of Hancock 2 valves there, and the gradients across the Hancock 2 valve are not as good as with the Avalis valve. And because of that issue, we ended up doing a lot of patch enlargements. But one thing I learned there from Tyrone David is autologous pericardium is a good patch material in adults, and that we never used any sort of glutaraldehyde fixation. And even to this day, that's my practice. And you do see some patients also, especially the bicuspid patients, that have a large annulus, but their sinotubular junction is not very big. And oftentimes with those patients, that's where the sizer really hangs up, and you don't actually have to make your patch across the annulus itself, but more just in this across the sinotubular junction and into the sinus of Valsalva, which of course is an easier method. Thomas, do you have any comment what you use for patch enlargement?
Yeah, I use pericardial, and I try to take a large segment, actually larger than usually, and I don't tan it anymore with the glutaraldehyde. It's a bit more tricky, but what I do is I try to fix it up and down, and then do my running sutures to keep it stretched, actually. But I try to avoid glutaraldehyde for the same reasons that you may have some time. It gets shrinked a bit, and some reports of earlier calcifications even at the patch itself, and it doesn't have a good form. But I mean, to be honest, to be a bit more provocative, so this is a very big study, more than 1,000 patients with excellent outcomes that compares very favorably with the eldest valves that we have and those with which we have longest follow-up. But if we bring the debate back to what we have with TAVI, so we have 4 years of follow-up, we don't have enough durability. How would you position this in your practice? This is a very easy valve to use, to be honest. Very straightforward, low profile. I like it very much. But if we say that TAVI should be limited because of durability, is Avalis suffering from the same limitation or not? And why not?
Well, to some extent, you have to be careful with every new valve that you don't have the data to support its long-term use, basically. But on the other hand, the materials that are used and the techniques that are used to prepare this valve are not new. The valve is not crimped. The pericardium is well known. The AOA treatment is known and used by Medtronic in other valves. So I'm not so doubtful that this valve will last much longer than, I don't have doubts that it lasts shorter than any other pericardial valve on the market. So it has to be seen whether it lasts any longer, but it's the techniques and all the treatments are exactly the same as are well known. And for the TAVI, it's the big questions are obviously the crimping and what those effects have on the pericardium. That's all we don't know.
Okay, thanks, Robert. Niels, I have a question for you. You had a great presentation there. The technique is you made all of those great points there. My question to you is, have you seen changes in practice, or do you think that the newly published ESC guidelines will lead to changes in practice? Because as you know, the surgical portion of the guidelines got a little bit less attention this time around compared to previously, and do we need more good high-level physical surgical data in order to get more acceptance within the cardiology community?
Well, actually, there's lacking a lot of literature about surgical ablation, especially for standalone treatment. But the point is that I think we should not focus on which is the best treatment modality, like percutaneous approach or surgical approach. The question from the patient is always, please, doctor, treat my atrial fibrillation. So I think we should collaborate with a lot of centers to look for the most ideal sequence, for which I mean, should the sequence be percutaneous first and then epicardial treatment, or should it be the way around? So I don't think we have to put too lot of energy and money in the studies, a catheter versus surgery, but we have to look for the right sequence. And during the years, there is tried with a lot of techniques to make a nice box lesion. And I think the strong part of the surgery is only that we can make an epicardial box lesion. And all the other lines and all the other connections can be done by endocardial modality. So yes, we need more data, but we should not stay around in our surgical community, but collaborate with our EPs.
I think that's a great point that we can generally make for optimizing cardiac care. The title of this session, I'm firmly convinced that we need to work very closely with our cardiology colleagues and not see them as competition, but see them more as collaborators and complementary therapeutic methods that they offer. And because there's no doubt about it, we need to work together if we want to try to come up with the optimal solution for the patient, and not just be thinking about ourselves or about our financial issues, like you so elegantly stated, Niels.
And the point
So
is that, yeah.
I mean, just to go in your direction and what Michael has been alluding to. So you've been advocating the necessity of having a heart team, which is not only dedicated to valve disease, but also AF treatment. So you're very open-minded. What's in your mind, limiting the because you've been showing that this procedure is safe, is effective, it has a consistent number, very good percentage of success. So why the cardiologists are not referring more patients to surgeons to treat this, to use this therapy? Why the cardiac surgery units are not more integrating this kind of treatment? What are the limitations to expand this today?
I think there are several reasons. First of all, I think they have probably, the older cardiologists have experience with the Cox-Maze 4, and they think it's very big surgery. So they think it will lead to complications. But the thing is, in the Netherlands, we have a great collaboration with Leiden, Maastricht, and some other centers. And the point is, in the Netherlands, there is not really a financial incentive. And you can imagine in countries where the cardiologist is treating the atrial fibrillation, and there is a great financial incentive to do again percutaneous treatment, it's very difficult for them to refer to the surgeon. Furthermore, we haven't convinced the EPs that our treatment is really a good treatment. We are lacking data with very big trials. Unfortunately, the case IAF trial was published, and that's again versus The point is that we should focus on which patient we should treat. I mean, for aortic valve, we know exactly what are the cutoff values for operating a patient, yes or no. But we don't know even what's the reason for atrial fibrillation. So we don't know which patient benefit from which treatment modality either. So we should deep dive in, for example, in preoperative cardiac mapping and look which are the failures. Both treatment modalities have failures, but we need to find a diagnostic evaluation about the atrial fibrillation. So that's not clear. That's not clear for cardiologists, and it's not clear for surgeons which patient to treat.
Okay, Niels, thanks very much. We do have to wrap up here quickly, but I just want to ask Omer one quick question. It was a great presentation. I'm also completely convinced from the Triad 2.0 ring, and it's now my standard of care. Are there any, do you think it's required? First of all, I'd like to mention there's also a Medtronic training village session just on tricuspid valve repair, which has more of the sort of tips and tricks. But a question to you, do all tricuspid valves need a ring? All repairs need a ring?
In my opinion, yes. I think we have not so good results with other techniques, so I will use it always because it is very simple, and the results, the long-term results, are much better with the ring.
I completely agree with you. Thomas, do you want to wrap things up then?
Yeah, I just want to say that I think this tricuspid presentation is also very important. We just published recently from a French registry a big series on outcomes in patients who needs tricuspid surgery who didn't get it, and it's definitely an unmet need, and we need to develop and promote much more this surgery also, especially that now we can do it more and more using minimally invasive access and beating heart. So again, thank you very much for this wonderful presentation. I mean, very quickly, I was very pleased to co-chair this session with you, Michael. For building the we saw the huge experience with the Avalus in the Paragon study, and we just have to wait a couple of years to confirm the durability, but already the results are very promising. Niels have shown clearly that there is a need to think or reshape cardiac surgery teams and adopt and promote the AF treatment in a new fashion and being more integrative. Primum non nocere, I use the same one, I like it. And of course, Omer has been talking about the tricuspid surgery, with these wonderful results with the band that we were talking about. So thank you very much, all of you, and I hope we will have the opportunity to meet physically again in the near future. Thank you very much.
And thanks to Medtronic. Thank you.
Bye-bye.
Bye-bye.